So I hope you are fresh and ready to listen another presentation. Related to the title of my presentation, the first question that arises is, why do we need a new paradigm in the approach to osteoporosis? The answer is very simple and clear. There is more than enough evidence indicating that common clinical practice based on pharmacotherapy, introduced almost 30 years ago, did not solve nor diminish the problem of osteoporosis. On the contrary, we face the new problems. So new problems have occurred, such as adverse events on drugs, jaw necrosis, and particularly atypical fractures after longer treatment of pharmacotherapy, among which the most common is the spiral fracture of femur. Very common came together on both legs. So patients are taking drugs to prevent the fractures. Instead, after some time, they got the worst one. How we can explain that? What happened with that guidelines? So in next few slides or next few minutes, I will try to explain you what happened based on my own experience, because I was in this story from very beginning, even before that. So it is important to understand that this clinical practice is based on the paradigm adopted on the medical conference, well known as Consensus Conference, in 1994, which explains osteoporosis as a consequence of reduction of bone mass due to increased bone resorption over bone formation. So it seems quite logical if osteoclasts resorb bone more than osteoblasts create the new bone matrix, the level of bone mass will go down, and in a certain moment fracture will happen. Very simple concept. Based on this, densitometry has been introduced as a main diagnostic criteria, and pharmacotherapy with idea to suppress osteoclasts. And when the first drug, famous Fosamax, alendronate, came on the market, approved 1998 and came 1999, pharma industry started with aggressive, strong promotion, trying to inform or explain to doctors what to do. What is osteoporosis? Because osteoporosis, the term, the name, have not been used in medicine. For the first time, it was introduced on this in this consensus conference. To make all the story more easier for the doctors, because we all been aware that doctors are not educated much about the bone biology, don't know much about that, except that there are some osteoclasts and osteoblasts, that's all. The story needs to be very simple. So also doctors didn't know much about densitometry, because that was not a medical procedure, never learned about that. I knew in that time something about that, because that was my master from 1985. Before DEXA machine has been introduced. But that was my master, so I need to learn how it works. Basically, what densitometry is doing. Source of energy. During I did my master, there was radioactive americium. DEXA machine used X-ray, emitted photon of energy, which are passing through the body. If the tissue is more dense, more photons will be absorbed, less will come on the probe, and on that differences, device calculated bone mineral content and bone mineral density. And T-score. What is T-score? Standard deviation from the average levels. So what we actually telling to the doctors during this presentation to be easier for them, you just need to do densitometry, just look the numbers. If you see T-score minus 2.5, perfect, that's osteoporosis. What you need to do? Give the drug. Simple, nice, beautiful. That was actually, I remember this period since 1999 until 2006, the best part of my professional life, because I was very much engaged in this promotion campaign. We travel all around the world doing presentation. Sometimes I have a feeling that I'm rock star because I give presentation in front of 1,000 doctors. Okay, I was a little bit skeptical about this simple concept because I had previous experience from nephrology, because I started my professional career in 1982, a long time ago, on dialysis, where we, for the first time, realized that bones is very complex tissue. So after this paradigm or guidelines has been introduced and widely accepted, actually the new problems and issues appeared, as I said. But before, first we noticed that almost 50% of patients, some follow-up studies shows that almost 50% of patients with fractures aimed minor trauma, which is actually the best evidence of osteoporosis, have a normal bone mineral density. Wow, what does it mean? It indicates that reduction of bone mineral mass or mineral density actually cannot be the exclusive diagnostic parameters. We cannot make diagnosis just reading T-score. And it also means that osteoporosis cannot be explained only by the decrease of bone mass. One of the reasons for that is this case, which still I can see very often. Very often patients came to me and said, look, I don't have osteoporosis. Doctor said I don't have it. Look, my densitometry, it's written normal. But if you look this side, you can see a lot of calcification, a lot of osteophytes, which is going to with osteoarthritis. And it is very common, particularly in older population, who have also osteoporosis. And look here, this is compressive fracture. And compressive fracture is the best evidence of osteoporosis. So this is not normal. These patients have severe osteoporosis with complication. So it's vitium artis actually. But whom we can blame for that? Doctors don't know actually that, because they never learn densitometry. What they have a chance to learn was what we promoted during promotional 5-6 years. Explanation is what I explained. If we have a photon of energy coming from source of radiation, X-ray in case of DEXA, energy will be absorbed in bones, but also in osteophyte and calcification because they have similar density. And if there is compression fracture, vertebra is compressed and density is increased. So it's very logical. What else happens? Some studies, I participated in some of them, based on histomorphometry. This is procedure, I don't know if you are familiar with that, but histomorphometry is doing after some kind of minimal invasive surgical procedure, transiliac bone biopsy. We need to take out big, it is not actually biopsy. We make trepanation to take out a big sample of the bone, prepare it on the special way, and analyze under the microscope. This method has been introduced at the beginning of 80s, late 90s, and I did it also. That's my PhD, and I did it a lot of these histomorphometries. So we can, if you look and do histomorphometry among the patients with osteoporosis, osteoporotic patients, as we diagnose it on densitometry, we can see in some patients they have this situation: a lot of osteoclasts, a lot of osteoblasts, everything is moving. So this is case where actually bisphosphonate, denosumab, pharmacotherapy can be beneficial. But this is only maybe 10 or 15% of patients with osteoporosis. Majority of patients have this: slow turnover, no cells, even this, a plastic bone. What we are going to do by giving the drugs? We will additionally support and deteriorate the bone. And that's the explanation why we saw fractures. So actually this experience, this evidence is the reason why pharmaceutical industry stopped financing education, promotion. So since 2007, no conference, no congress, no symposium about osteoporosis. I know that. But unfortunately, there is no new promotion. Because you know, pharmaceutical industry is only strong enough to finance everything. So after 2007, actually, all what majority of doctors have a chance to learn was what they listened during these 6-7 years. So it's not nothing strange, nothing curious that this practice is still mostly going on, despite it's not good. So we cannot blame doctors because they have no chance to learn something else. But that is the reason to change it and to promote it. So to understand what happened and what we need to do is that this paradigm adopted on the consensus conference is not based on scientific evidence, but rather on hypothesis that seems that most likely explanation of osteoporosis is the decreased bone mass. So that was just hypothesis, because we didn't know much about that. Frankly speaking, I think you know that. Until recently, the skeleton have not been even considered as an organ. Even now, we don't have a word for the biggest organ in our body. It is not skin. It is musculoskeletal organ, all which consist of all bones, cartilage, muscles, tendons, ligaments, and fascia. 80% of our body is that organ, and we don't have a name for it. It's telling everything, actually. So scientific research on the bone metabolism began only after introduction of bone histomorphometry, which I just explained. And that was introduced at late 70s, beginning of 80s. And that was for the first method, and the only one, able to provide insight into the structure of the bone and open the door of further development of modern osteology. So it happens actually 45, 50 years ago. almost when I started my career. But I'm still here. So it's very young. So the incentive for that was actually an incentive to see the inside of the bone structure, microstructure, was actually experience noticed after chronic dialysis has been introduced. That fractures are very common in young people on chronic dialysis. Until that time, we all believed, all people, all bones. Everybody have pain. What we can do? Nothing. We can maybe replace hip, knee, do some physical therapy, and that's all. That was very common, even now. And then suddenly, young people on dialysis, 50, 60%, maybe 70% of them has the fractures. So we need to see what is below. This is like this. This is a nice comparison. So I always remember this, how I felt when I started to work histomorphometry. If you just look on the surface of the sea and never dive below, never see the photos, never see the movies, how it looks like below, how you can imagine what is below? What we can see from the standard diagnostic procedure, X-ray, CT, even MRI, we can see just the changes on the surface, which is a consequence of the process inside on the level of microstructure. And when you dive, you see, you discover the new world, microcosmos. Everything is very dynamic. A lot of cells. You can see this, 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 this. And this is all patients with renal osteodystrophy. But the same is with patients with osteoporosis. So osteoporosis or renal osteodystrophy is not one disease. It's disease with 100 faces. And it is very important to understand why. It is clear that we cannot treat all these different things by the same type of drugs, by suppressing bone turnover. So that's so since there were no studies based on histomorphometry during the 90s in osteoporotic patients, it doesn't surprise that clinical experience after these guidelines has been introduced did not support actually this paradigm adopted on consensus conference. As a consequence, what we can say about osteoporosis today, despite the fact that we are dealing with that problem 35 years? Osteoporosis is among the most common disease, still underestimated. Significant public health issue and a severe financial burden for society. You know what was the main trigger or incentive why actually World Health Organization organized consensus conference in 1994? Observation and calculations done from the insurance company from United States that the fractures in menopausal females cost $29 billion per year only United States. If something costs $29 billion, that is the question, guys, what we are going to do about that? But recent financial data in only 5 countries in the European Union shows that was data from 2017. The cost of fractures, only osteoporotic fractures, in only 5 countries in the European Union is now 40 billion euros per year. And estimated increase is 38% until the end of this decade. It's huge, and nobody talks about this. We can hear from the media only the same story. What is the biggest health problem of our civilization? Cardiac problem, tumors, diabetes, dementia. But what about bones? So it clearly shows that our civilization, even medicine, doctors, still are not aware of the problem. So osteoporosis is not just a very common and very expensive problem. It's a big and serious disease. 80% of the patients after hip fracture stay for life. Depends on the others, invalids. So you can imagine what does it mean, 80%. So it is more than enough reasons, and question is, could we improve the treatment and prevent complications? Or are we stuck where we are now? The answer is yes, but how? We need first the new paradigm based on scientific facts. So we need to accept, we need to see what we are going to do, because that is a paradigm. And that paradigm, so how to create it? Let's start from very beginning. What we know about the bones. First of all, good thing is that in the last few decades, intensive scientific activities significantly increase our knowledge about bone biology, confirming the need of changing our common clinical approach. Also, advancement in technology like MBST and science provide us with the possibility of better and more successful treatment. That's the key. So it is not just academic discussion. It is real. We are missing to treat our patients better. And we need to be aware of it. And we to said it, to tell that to the colleagues and to the world. We can better. But still, we have a problem because bone biology is not yet a part of standard education. No any university, no medical school, so our knowledge about the bone biopsy is very poor. Osteology as a medical discipline doesn't exist yet. We have orthopedic surgeons, but that is surgeons. We have physical therapy, it is one part of the therapy. It's the same like we have no cardiologist, only cardiosurgeons. So you have a pain, direct to cardiosurgeon and he will put it on the table. So we need to organize infrastructure. We need to change first definition of osteoporosis. Since the main problem of osteoporosis is fracture, that are a consequence of low bone strength, not bone density or bone mass, bone strength. The appropriate definition of osteoporosis should be osteoporosis is pathological condition, not disease, 100 disease condition, characterized by low bone strength and an increased risk of fracture. This is first thing what we need to understand and accept. Second, we need to understand what actually influenced on the bone strength. Bone mass, but not much. Most important are the bone collagen, osteoid, soft tissue produced by osteoblasts, and the microarchitecture. That could be very easily understood if we make comparison with concrete. Everybody knows that reinforced concrete can take much bigger load than simple concrete. What is different? The difference is only in the steel net. That steel net in bones have a osteoid, collagen. But that is a problem also because the collagen have no high bone mass and no high density. And densitometry are not showing how this collagen is. And this is not only how it is fresh or old, how it is flexible. Collagen gives flexibility to the bone and create bone matrix. Part of this collagen is mineralized by embedding crystals of calcium hydroxyapatite, but not all collagen, because if it will happen that the bones will be less flexible and will be broken. So, for example, beside that, also it's very important how this collagen is organized. It must be in linear manner. That's the problem, for example, for hyperparathyroidism. Usually people think that the problem in hyperparathyroidism is that the bone is too fast remodeling and calcium goes out. But actually, bigger problem why bone is weak in case of hyperparathyroidism is a woven structure, because osteoid is not mature well, and instead to have a lamellar organization, it is organized like a wound mark, so we call it woven bone. The same importance has infrastructure of the bone. We know that bone is changing every day, but it is not just a simple replacement. We call it remodeling. This is an amazing process. What does it mean, amazing? Why it is important? Again, one very simple comparison. Everybody lives in some building, in some house. Everybody, maybe some of them constructed. What is important? The static. Why static? We need to create the bearing wall where the load is the biggest. But in case of building, it's easier because we are not going to move this building much, but we are moving. So bones need to adjust its interior structure every minute. Sometimes we are sitting, then standing, then jumping, then we can go on the space, and that influence bone needs to adjust it. That's the purpose of bone remodeling process. So this is how this process is going. It's an amazing story. It's very important. This is the crucial for understanding bone biology. Bone architecture is constantly modified through bone remodeling, trying to provide optimal bone strength, which is influenced by biological, biomechanical balance, as well as genetic. But how it works basically? We know that we have osteoclast and osteoblast in the bones, cells. Osteoclasts resorb, osteoblasts create bone matrix. But there is a third cells, osteocytes. Osteocytes are the most number in the bones. I remember when I did this histomorphometry, I always ask myself, what the cells are doing? Why there are so much in the bone? They are the key. They are the sensors and the brain of the bone. Bone is intelligent organ. How it works? These osteocytes detect vibration inside the bone. What causes vibration? Muscle activity. And based on that, they coordinate osteoclast and osteoblast. We know this rank-rankle mechanism. And tell to osteoclast, demolish this wall, and osteoblast, don't do that here put, because this is vibration the most intensive. So this is really intelligent process. And the bone is a fascinating tissue or organ. What is the proof for that? Number of it. The most simple, most clear case with astronauts. 25 years ago, even before, have been reported that astronauts who spent only 5 months in space station, healthy person, young, well-trained and male, got osteoporosis after they come back to the, what they miss there. Okay, family, lover, wife, kids, but all of them miss gravitation. No gravitation, no contraction. It's very clear. Proof number 2, sarcopenia, low bone mass. All people with low bone mass has osteoporosis as well. Oh no, muscle, sorry. Sarcopenia is a low muscle mass. Proof number 3. People who have because of some reason, for example, neuromuscular disease or something, cannot move, always have the osteoporosis or reduced bone strength in those legs or arms which is not moving. And third, which is very important for us, if somebody has pain, back pain, because of protrusion, because of the osteoarthritis, and cannot move properly, or have a flat feet, or have or walk like this, or have any kind of the disturbed statics, scoliosis, for example, for sure, those persons first will develop osteoarthritis and then after osteoporosis. So osteoporosis and osteoarthritis is going together. That's very important to know because we cannot treat osteoporosis as the separate disease and osteoarthritis as we do. Sometimes doctors say, you have osteoporosis, go to this doctor. You have osteoarthritis, you go to this. No. Such kind of patients need us. We need to treat skeleton as a whole. Because skeleton is complex organ, as I said, consists of different tissue and needing all of them to act in a harmony, like symphonic orchestra. If one violin starts to play wrong, the guy on the piano will also start wrong. And very soon all the orchestra will play wrong. What conductor needs to do? Make a harmony. That's what we need to do with the skeleton. We need to make a harmony. How to do that? So this is just a brief explanation what's going on based on what I just said. Skeleton is constantly adjusting to biomechanical and metabolic balance. Due to gravity, it absorbs various loads constantly during the normal daily life. Skeleton is specially designed to reduce overload by distributing it equally to all its parts. Why we have double S spine? While we have not flat then feet like this. There is a logic in that, to distribute the load equally, that all parts of skeleton participate weighting it. So if it's not like this, in case of the skeleton deformities, all disproportion which cause overload, like sport, for example. The best example, why a football player cannot play anymore after 33 years old? Everybody except Luka Modric, probably you know him, 38, but no others. Because in football player, the load is particularly hit on the knees, and they collect a lot of damages. But also sedentary life. So osteoporosis is not a problem of calcium intake from the food, because in that case that will be a problem in Africa where people are starving, not eat. Not in America where every person drink at least 2 liter milk per day, or here or in Croatia or in Europe. So osteoporosis as well as osteoarthritis are the problems of developed countries, not poor countries actually. And so lifestyle, that's very important. What we are doing mostly, sitting in the car, in armchair, everywhere. And if we are moving, we do sport. But sport is not healthy. Believe me, I'm doing sport for my childhood actually. I'm master of Taekwondo, 7 done. I know what is sport. I've been on 5 Olympic Games. And we hear Mr. Nelson this morning. Exercise, yeah, essential. But sport is not the same, particularly professional sport. So what happens if overload exceeds the regenerative capacity of chondrocytes? That's also a problem. We know that chondrocytes, the factory of collagen, cells which produce the collagen, it's quite lazy cells. They produce less collagen than, for example, fibroblast skin. Skin can regenerate more faster. But it is not true that cartilage cannot be regenerated. The truth is that we cannot regenerate cartilage by the drugs. But every tissue have potential because, as you said this today perfectly, what we are products of our cells. Quite famous scientist originally from Croatia, Miroslav Radman, said something in one interview, and I like to repeat it. He said like this: aging and disease are the result of the same process, corrosion of the proteins. He wants to say and explain later that all we are, our body, bones, cartilage, skin, brain, vessels, all are the products of our cells. And our cells all the time need to produce it. We are not born in certain day and die in the other day. We are die and born every day. So our cells, billion of cells, are billion factories. What factory needs mostly? What is essential? Of course, manager, workers, but if you take out electricity or stop energy, stop production. So energy, as you said, is key. So that is why MBST is something new, something we need to understand, and that's the value of MBST. So, because there are no, just to finish this, we know that at the beginning, as you also said, that at the beginning of osteoarthritis, no symptoms. Nobody care. We don't pay much on this. People don't, oh, I'm okay. But we should know that the pain, why they don't have a pain? Because there is no nerves in cartilage. We know that. Why we cannot regenerate or repair cartilage by drugs, injections? There are no vessels inside. But what is inside? Water. Why MBST can do? Because there is the water, hydrogen ion. Don't need vessels but why this that there is no nerves is important, because there is no sign. It would be much better that we feel the pain on the beginning. So the process of collecting damage, cuts, lesions are continuing. And because our chondrocytes is a little bit lazy, they cannot produce enough cartilage to regenerate all this lesion. And what's happened? The same if we cut our skin deeply. What will happen? fibrotic scar. So by collection, the fibrotic scar inside the cartilage change capacity of the cartilage to absorb the load. And what happened? Load spreads on the other tissue, tendons, ligaments, fascia, bones, and cause the pain because there is a lot of nerves, swelling. So this is not beginning. And we said, oh, now we have diagnosis. This is osteoarthritis. This is complication. And also, it has a consequence on the bone because we start to go like this or to sit more, and bone will deteriorate. This is symphonic orchestra. Started with violin and finished with all. And therefore, we need to treat skeleton as a whole. Additionally to biomechanic, genetic factors and metabolic balance also have significant role. For example, we know that diabetics has a higher risk of osteoporosis and osteoarthritis. And at the end, so due to the fact that functional ability of skeleton depends on the quality of all its parts, the holistic concept is always necessary, treating the skeleton as a whole. That's one of the cornerstone of the new paradigm. Second, we can say like this. So, bone strength and quality of skeleton in general depends on genetic, biomechanical, metabolic, biochemical balance, and biomechanical, and all of them acting, influencing together. So what we have here is actually resultant of the influence of many things. We cannot say, this is the cause because of that. No, everything. So I don't like, for example, we still can hear that menopausal osteoporosis. There is no such thing. Menopause is one of the reasons, but it's not the only one. Due to the significant variability among humans in terms of genetic diversity, biochemical and biomechanical balance, somebody has diabetes, other no, somebody has scoliosis, the other no. The treatment needs to be based on personal assessment. We cannot make diagnosis on densitometry, on DEXA or X-ray. We need to talk with the patient, to ask, to see how he is or she walking, how he's sitting. And principles of integrative medicine using combination of methods to achieve complementary and synergistic effect. And this is a schematic how I suggest to remember the new guidelines. I use this abbreviation BAR just to have a good association on bar with a glass of beer. B stands for biochemical and biomechanical balance corrections. We need to do that if it's possible. Also, we need to provide regular biomechanical stimulation. So the key methods are exercise, MBST. Sometimes also we can add physical therapy. It's always personalized. Sometimes surgery also. Vitamin D, sometimes some other drugs. A stands to analgesia. If somebody has a pain, we need to treat the pain as well because people cannot move with the pain. So again, MBST, also acupuncture, physical therapy, drugs, synergy, and R, regeneration. Right now, only what we have is MBST. So MBST is all these points. Since there is no effective therapy able to achieve complete restitution of the skeleton, but there are treatments that can prevent most of complication. Prevention, as you said, is the key, like in hypertension case. Prevention. So the focus needs to be on early prevention. The same story like in hypertension. We are not going to treat hypertension with after patient have a stroke or myocardial infarction. Of course, we would give it, but the focus is to prevent that. So all patients with the risk of osteoporosis and fractures, for all patients, it is recommended to assess bone strength. It's not complicated. Just talk with the patient, maybe do also densitometry is useful. Bone markers, some biochemical markers, and make assessment. We cannot measure bone strength. That's the problem. We cannot measure quality of collagen as well. But we can make assessment. We can make quite a good assessment. It's not complicated. It's not expensive. Just we need to talk with the patients, to see the patients, not just papers. And we need to make a plan of prevention and treatment. And it is actually very simple. If somebody who needs early prevention? Whole menopausal women. People or corticosteroid therapy, we know that that is a high risk. People with rheumatic and autoimmune disease. People with weak kidney function, dialysis and transplanted. People with diabetes. Actually, I never get the patient from diabetologists. They need to learn that their patients have high risk of osteoporosis, so they need to make an assessment. If they don't know that, they need to send somebody who knows. Then people with spinal deformities, scoliosis, kyphosis, hip dysplasia, avascular necrosis of hips and knees, foot deformities, and after orthopedic surgery. People with chronic bone and joint pain also. People with low mineral density on densitometry, despite the limitation of densitometry. My opinion is all people with low BMD deserve treatment. What kind of treatment it will be, that's a question. But we cannot say, densitometry is bullshit, or go away, you are good, you have no fractures. No, the value of densitometry is that it is simple, non-invasive, and cheap. So we need to do that, particularly if we have, I heard that it's ultrasound now, but I remember 30 years ago, we have also ultrasound densitometry for calcaneus, but maybe this is the better. And I would prefer also to suggest to do that prevention to everybody over 60 years. What prevention? The best prevention is we have method with the approval, with the confirmation, scientific and from the practice, that it works and that they have no side effect. Again, what is that? MBST. We heard this today. I'm doing MBST for 17 years. No side effects. Exercise. Actually, this is very important. What I'm doing, I'm teaching my patients TEDO exercise. We have video we can send to you. What is TEDO? Actually, I prepare it 25 years ago, based on my experience from Taekwondo. And based on the knowledge or informations, as I explained, vibration is the key. So what exercise need to cause? Contraction, rhythmic contraction. Rhythmic contraction caused vibration, sending the signals to the osteocytes. And so I did it just to make more plausible for the patients. It is just 13 easy doing motion, doing in the chair, so everybody can do that, cannot harm themselves. So all people with some problems, some heart disease, everybody can do that at home. We have a video, we usually free of charge send it to the patients, and I always said, look, open the TV or WhatsApp or whatever, look to Maya. Maya is our physiotherapist, she demonstrates, and work with her. She is talking, so you have a feeling that you are in the group. Or you can do it in the group. We did it in the group, but after Corona, we need to stop with that, so we replace it with video. So at the end, I will just show you maybe 3 or 4 my clinical cases or patients from my clinical practice. It's okay. Just to see how I see the things, what I'm doing in my professional life. So this is one case, so it's one patient. In the time when he came to my clinic, he was 71, suffered from chronic pain related to severe hip osteoarthritis, confirmed with X-ray, magnetic resonance, so as well as knees and lumbosacral spine, confirmed by, again, with all these diagnostic methods. So no doubt, patient had severe osteoarthritis, barely moved, and in spite of repeatedly conducted physical therapy, the progression of the disease caused limited mobility. Getting the patient scheduled for the surgery, and of course, orthopedic surgeon suggests the left hip replacement. So my assessment was, yeah, maybe the most possible would be the best would be to do really hip replacement, because I didn't believe that we can do something because this hip was completely destroyed. And we have a lot of things other to do. So I suggest to the patient, okay, go to surgery, but before, we are going to do MBST, but bone program. Why? To improve the bone quality, to improve the bone strength, to renovate the bone cartilage, because the surgeon need to place the endoprothesis in the bone. If the bone will be better, that will be better placed. So we did it. Then he goes to the surgery. When he came back, we did isokinetic dynamometric therapy to adjust the new balance, because it's now changed. And we continuous with MBST program for osteoarthritis, the knee and spine, and exercise. And so we cannot just stay on the hip replacement. The guy has the problems in general, not just the hip. And we need to treat the whole skeleton. And he is now 79. Today, maybe more. And he's fine. The other case, female patient, 70, when she came to me, with previous fractures and chronic back pain, severe osteoarthritis of hip and spine, confirmed by X-ray, MRI, low BMD on DEXA. She has been treated with bisphosphonate for 5 years, but treatment has stopped due to adverse events and the fact that she experienced a fracture despite the therapy. So I recommend her to stop, of course, pharmacotherapy, and that we do MBST and repeat it after 6 months for program for osteoporosis, 10 days, but also program for osteoarthritis, spine and both hips once per year. I do it very often, not just osteoporosis program, also for osteoarthritis to improve mobility. Also exercise, vitamin D, and she is fine. No any more problems, not significantly much less pain, and she is mobile without fractures. The other case, it is also interesting because it's not common that rheumatologists think on that way. So the guy, female patient, came to me because of rheumatic arthritis under standard treatment, methotrexate, and also they did Medrol because rheumatic arthritis of more than 10 years, so long term. And the patient came in because of constant pain on both hands, left knee, despite the increased dosage of the DMARD therapy. Usually rheumatologists, what they do, when patients are on the treatment and then came and said, I have again pain, they immediately increase the dosage. But in many cases, the pain is not caused by a relapse of autoimmune inflammation, that because of the deformity of, like in osteoarthritis. So we cannot solve it by increasing the dosage of the drugs. Additionally, many patients like this one taking corticosteroids. So we treat rheumatic arthritis, and as a result, we got the fracture of the back spine, compressive fracture of hip. So we need to treat also bones to prevent this. So we did it. And okay, this is just your information. What I'm talking to you is already published. So it's nothing which I just invent from my head. That was 2 books. One was published 3 years ago by Springer. You know, Springer was a respectable publisher. The book is Personal Medicine in Healthcare Systems, and I write down the special chapter dedicated to the bone, which describe the new paradigm. So you can find this. And the other is, this is an American publisher, similar topic, but more focused on economy. And for the end, why I put here these 2 young persons, young couple, I really believe after 45 years almost experience in the bone, it was not my option. Actually, I never think that I will work with the bones. I told you that I started my career in 1982. And when I came, I got a residency on the dialysis department. I was a brilliant student. I was so ambitious. I was see Nobel Prize for me at the end of the corridor. So that was my force. On the first meeting with the chief, with the head of the department, he told me, colleague, your first task is to deal with renal osteodystrophy. I almost fell down from the chair. What he is talking about? I never heard about that. What is the renal osteodystrophy? But I know everything. How I don't know that? That because in that time, nothing about bones. So I collect my first information, first knowledge about bones from the medical conferences, because in that time that was quite a lot, because dialysis is expanding. And one of the topic always was bone, renal osteodystrophy. And there was different hypotheses, like in osteoporosis. At the beginning, we thought that everything is hyperparathyroidism secondary, so we cut the parathyroidism, and then, oh no, sorry, it's not for all of them. And finally, I was lucky, actually. I met Dr. Veljko Matković, Croat, who lives and works in America, United States. In that time, young doctor, but later he became professor in Columbus. Now he's in state, but retired. He was working in the center where histomorphometry has been introduced. And I think it was in Lisbon or somewhere. I was sitting in listening, and it was announced, next speaker will be Dr. Veljko Matković from Henry Ford Hospital, Detroit. He is going to talk about transiliac bone biopsy and histomorphometry. Wow, I heard about that, but I didn't know anything. So I just jumped when he finished, ran, keep him and said, you need to teach me that. So I have lucky, actually, because I found myself among the maybe 10 first persons who first time saw infrastructure of the bones, actually. And that is the crucial for my understanding of bones, and I must say wider of it, also a medicine. So I think that our job is not just to do in our clinics. We need to teach the people. We need to spread this information, because I really believe, that's the reason why they are here, after all this experience, that at least 80% of people, of population, could live good life without any pain, problem with the skeleton, without any fractures, 100 years, 150 years. because vast majority of the skeleton problem is not caused by virus, which we cannot predict, bacteria, or some autoimmune disease. It is caused because of our lack of knowledge, because of lack of prevention. But we now have some knowledge. We have some tools for that, like exercise and MBST. So it is not only a matter of academic discussion, as I said. It's a matter of our responsibility. So while I'm still doing what I'm doing, I am old enough, I can go. But actually, I think that it's my duty, my obligation to spread my knowledge and my experience. Maybe I'm not in all things right, but I would like that people try and start to think. The problem with our doctors nowadays, it's not anymore now, it's last 30 days. Doctors are not learning biology. And you know very well how it looks. We have guidelines. We are just follow guidelines. What is guidelines? Somebody else create guidelines, some society, with pharmaceutical industry, of course. I don't have, we cannot say, oh, this is mafia. No, it's not mafia. But we need to understand that our responsibility is not just to follow guidelines. I know that it is much easier. No responsibility. I'm not guilty. That's not my fault. Look, that bring the guidance. But we cannot go away. We cannot be blind. We have responsibility. And we must talk. We must change whatever we can. Of course, with some evidence, with some knowledge, with some experience. Thank you.